Hello, my name is Kate Steiner and I'm an interventional radiologist in the UK.
Hello, I'm Matteo Tozzi, vascular surgeon from Italy. This study reinforced, in my mind, the positive action of the DCB in different areas. For first, the anastomotic area in native fistula, the venous outflow, and also in cephalic arch. This last area is, today we have a lot of debate and the superiority of the angioplasty versus stem graft. But I think today, I don't know if Kate had the same idea, is not a war from device, but is necessary to decide the correct sequences of device. So in this area, in my mind, like the result of IN.PACT AV Access, I use for first time the DCB, and then when I have a failure of the DCB, a rapid recovery of stenosis, I use the stem graft.
I think in my mind, the IN.PACT AV Access study is high quality level 1 evidence that DCBs are effective in treating AV access stenosis. And it's a proof of concept study. Looking at some of the subgroup analysis, as you pointed out, the cephalic arch and for those inflow lesions were maybe some of the areas where we saw really good results. Has it impacted my practice? Yes. I'm more confident now using DCBs and spreading the word kind of to my colleagues who also treat AV access stenosis. I think we don't have any trial evidence as yet specifically directed at de novo lesions, although we do have evidence of level 1 evidence with, for example, the IN.PACT AV study of the use of DCBs in AV access. We know that they are effective. I think that one of the issues has been, what are we treating in terms of the pathophysiology? And now we know that some lesion types have intimal hyperplasia. And we know that from the studies we've done looking at the ultrasound and correlating with histology, then it makes scientific sense that by applying paclitaxel to those lesions, we're targeting the intimal hyperplasia, and that should have a good result. And patients would go longer between treatments, but we do need the evidence specifically directed at that now that we have some scientific basis for it.
I agree with you. Today we don't have evidence, but I think from the pathophysiology of the intimal hyperplasia, the first part, when the stenosis is born, we have a lot of cell inactive replication and inactive production of a lot of collagen, the matrix. So I think in my practice, I see when I treat for first time with the DCB, the novo lesion, the interval free from the stenosis is more longer compared to a stenosis treated previous time with other type of angioplasty, high pressure or other device. The DCB, the paclitaxel is not a magic powder, so run very well if we have a lot of cell in replication. So the combination of two different action, mechanical action from PTA and DCB is optimal. But probably the goal for us today is choosing the morphological lesion with perfect result for DCB. This for me. So I think the novo lesion is better choose a DCB for first line treatment.
Do you treat them, Matteo, the de novo lesions first line with the DCB? I do. For those lesions with hyperplasia. Anecdotally, when I follow them up, they seem to do well.
Yes, but at the end, the guideline is based on fantastic statistical randomized controlled trial, but the basis for this fantastic trial is the standard practice that we perform in real world. And I think for surgeons, for interventional radiologists, for nephrologists, and for patients, the interval free of stenosis is the goal. First of all, the teamwork. To have a very good team with nephrologists, nurse, interventional radiologist, because the follow-up is mandatory. I think today the endovascular approach today is the gold standard because allow for the patients a short hospitalization. So in my mind, in my practice, the first treatment of my patients with a problem discovered during a follow-up is an endovascular approach. I think Kate performed the same, but I don't know.
I agree completely. I think, again, for me, as Matteo said, teamwork is the most important thing. Having robust pathways and protocols in place so that you can see and treat patients in a timely fashion. So getting to those clotted access early for intervention, and also picking up dialysis access dysfunction early. I think that following your patients up, as Matteo said, is really, really important. And I've learned a huge amount by seeing patients beforehand, performing the intervention, then following them up, and you find out what's effective, what's not effective. And also it's a chance for the patients to tell you little things about their experience, but establishing that kind of trusted relationship with your patients is extremely important.
Yes, Kate, I agree completely with you. Each time that I speak about the use of DCB, my mind is very clear one factor. The reduction of percentage of retreatment for each year for a patient is very important. These patients come back at hospital for hemodialysis 3 times a week. So if we add some other days in a year for PTA, for thrombosis, the life of these patients is terrible. So it's mandatory for us work for have this goal, reduce all the complication of our patient, reduce the percentage of retreatment. This is in my mind, a message is very, very strong, and probably is the message of IN.PACT AV Access.
Yeah, absolutely, completely agree. And when you're consenting patients for DCB use, patients don't really understand patency rates, primary patency rates, but when you talk to them about increasing time between interventions and some of the results from the study, that's when it becomes really meaningful for them as well, I think, in my experience.